doesn't just get into but it shows a little bit of the product, shows a little bit of
We'll get started in about 3 minutes. 3 minutes.
You know, I did.
We'll get started in 1 minute.
Started. This panel is on the future of healthcare philanthropy, and healthcare philanthropy can mean a lot of things. A lot of us think about it in terms of funding of hospitals for uninsured or what they call uncompensated care. And just to give you an idea, hospitals between 2000 and 2016 spent $538 billion on uncompensated care. That can include people who went to the hospital and did not pay their bills. although that's sometimes separated out as bad debt. Anyway, there are also other areas of healthcare philanthropy, including patient support services, research funding. It can also be education, and it can also be funding nonprofits. And we're going to hear a little bit about all of that. So I'd like to introduce our panel. Sitting next to me is Earl Maxwell. Earl and I are old friends. He has been at the St. David's Foundation since, Earl, 07, so almost 10 years. He's also served on boards, so he has about a 19-year history dealing with healthcare philanthropy. And then next to him is Kathleen Gibson, and she is the president and CEO of Southwestern Medical Foundation. Primarily they fund Southwestern Medical Center in Dallas, but they are not an arm of that. They actually owned the hospital at one time and gave it away. So, and then next to her is Greg Lee, who some of you probably know from the Livestrong Foundation. He's been there for quite a while. He is the president of the foundation now, and that's been for about 2 years. And he's got about 15 years in healthcare philanthropy. So that's where they're coming from. And I would just like each one of them to talk just a little bit about what their organization funds and where the money comes from. So Earl, would you mind starting?
Thank you, Mary Ann, and thank you for having all of us on this panel today. St. David's Foundation is different than most hospital foundations. Most hospital foundations are set up for the benefit of the hospital they're associated with. Ours is just the reverse of that. We have a unique partnership with St. David's Healthcare, which is one of the 2 largest healthcare systems in the Central Texas region. And through that ownership, we have about a 42% ownership interest in the healthcare system. And then through that ownership, proceeds come out of the hospital into the foundation, and then we return over $70 million a year to the community for health services. And so that's a little background about the St. David's Foundation.
Go ahead and get started. I'm Kathleen Gibson, and Southwestern Medical Foundation started in 1939 after 40 years of tremendous work in what our founder called a medical wilderness, and that was the southwestern United States. He'd been educated at Bellevue in New York. He'd seen healthcare well developed across the country, but not here. And the idea was the whole southwestern region that needed to address the medical wilderness. So what we started out to do through his leadership, and he had been head of the TMA, he'd been head of the AMA at a very difficult time during the Depression. He saw that this landscape needed solving. And so 1939, 40 years later, he brought the foundation forward with community leadership and community leaders to address and continue to address medical standards, medical practice, medical growth, medical care. 1939, if you sort of think about what was going on then, my father would have been 10 years old. He would have lost his little brother to pneumonia in that year. And it was because they hadn't gotten their first shipment of sulfa antibiotic drugs that probably would have saved him. So we're in a landscape where you're pre-antibiotic, you're post-depression, you've got a migration in Texas to the cities from the rural areas. And it was a vast, complicated world. I say that to give us hope that we see a vast, complicated world in medical wilderness today. But the foundation was to bring the community to the issue and to bring the capital to the issue through the community. And it wasn't for the system to solve itself. It wasn't for the medical center to do it all by itself. It was to really start the medical center of the Southwest. They said, why not a great medical center in the southwestern United States? We had Johns Hopkins, we had Mayo, we had lots of Cornell type in the Northeast, but we didn't have anything here. So the foundation started to build great medical care in the southwestern U.S. It ended up that we lost our college to Houston 4 years later, 1943, during the war. And we started Southwestern Medical College in the foundation. and Southwestern Medical College thrived. 6 years later, we gave it to the state of Texas. That has been our primary beneficiary. The reason the foundation continues to be vibrant and vital and important is because we support the advances in medical research that will change healthcare for our future, have changed healthcare for our future, have solved many things that need to continue to be worked on. We educate through the medical center 60% of physicians in North Texas. There are 4,000 learners any day on that campus. That's extremely important to the future of healthcare. And then, of course, we help build buildings. All of the research and education and clinical care is for the purpose of improving our health. There's no other reason for us to exist. It's to improve the health of the public, to improve our health, to continue to change this landscape. The endowment today is about $850 million. Much of that is in research and education. We help in big campaigns. Big ideas are brain and cancer and metabolism. And of course, the great medical center of the Southwest is now a reality.
Well, hey, where does your money come from?
Many donors.
Okay, private donations, including
Many
businesses?
private donations, some private family foundations and some charitable corporate foundations.
Greg?
I'm Greg Lee, the president at Livestrong, and for 20 years we've done things a little bit differently. There's a lot of folks that focus on the disease of cancer and how that impacts a person's life. We're different. We focus on the person who has the disease and everything about their experience. So when they, 6 months after a diagnosis and they've got bills stacking up on their dining room table and they don't know how to pay for them, they can reach out to us. And we help folks 24 hours a day, 7 days a week, kind of go through those types of issues. And it's financial, it's insurance, it's access to clinical trials if that's a choice and an option they need. If they need emotional support services for them or their family, or they just want to have a peer conversation with someone else about the disease and the diagnosis and what their treatment look like. We've done that on the direct service front, served almost 4 million people during that 20-year history, all at no cost to the constituent. In addition to that, we've built over 200 community-based programs that really live and thrive in local communities around the country. Probably the most notable currently is the Livestrong at the Y program, which is a 12-week free fitness program to kind of help people get back up on their feet. That's now featured in Austin at 12 locations, but also at 600 other locations around the country. We've had some 47,000 participants again go through that free program. Most of our donations come from individuals. More than 75% of our donations and public support literally come from individuals who either participate in a wide array of events that we have in Austin and around the country, but also just private individuals who make the donations to the organization.
Just to give us some context, is the amount that you allocate each year, and I would like to know, I think Earl might have mentioned it, but is it going up or down now? And how much is it?
We spend about $15 million a year in public support for a wide array of programs. Those who are familiar with our track record and our history know we've had a few bumps along the road, but since 2015 we have been on the rise, and we're on the increase somewhere in the neighborhood of 18 to 23% a year over the last few years to that number.
So it took a little while to recover from the doping scandal with Lance Armstrong, and now you're on the upswing.
We're back on firm ground and headed in the right direction.
Kathleen, tell us how much you told us what your endowment was. Tell us how much you spend a year and whether or not that amount is going up or down.
It's a really good question, not a clear line trend. It's, I'm going to say if you had a campaign and you were building a big hospital, you might send out a huge amount of money all at once, as we did a few years ago for the Clements Hospital. So raising campaigns to set that aside and big years like that. A general year right now is $35 million to $37 million. It's going into research and education and some level of clinical care.
Or repeat how much you all provide, and it's to nonprofits.
Yeah, and when I arrived at the foundation 10 years ago, our budget was $9 million. And over that 10-year period, it has grown from 9 to 80 million.
To 80?
To 80. And it may not continue to grow infinitely at that same rate, but we've been through a very significant period of growth.
Do your fortunes rise and fall depending on how well the St. David's hospitals are doing financially?
Well, the St. David's hospitals are clearly our economic engine. So our, of the $80 million budget this year, we only raise $500,000 of that. And that's for the benefit of St. David's Neil Kasurik scholarships. We have an annual Toast of the Town event. But the rest of the money comes from investment earnings from our endowment, as well as excess earnings of the hospital system. And the one thing I didn't say earlier is our foundation's vision is really a big, hairy, audacious goal. And it's to help Central Texas become the healthiest community in the world. And a lot of people say, well, how in the world will you ever know that you've achieved that? We won't. But what we know is that for many of you in the audience, if you live in a neighborhood similar to mine, that's a nice neighborhood, that's safe, with sidewalks, and a lot of people walking and jogging by and walking dogs every day, and we're within a short jog to a Randall's or an H-E-B, and then there's a nice park. We're a mile and a half from Zilker Park. If you're living in a neighborhood like that in Austin, you probably already live in the healthiest community in the world. That's the good news. The bad news is 20% or more of our population do not have the benefits of anything I just mentioned. And so our foundation focuses on that 20% or so of our population, because if we can narrow that gap over the next 10 years, then we may be able to actually achieve the vision that I described to you.
We heard this morning, and most of you all know, that Congress is wrestling with repeal and replacing Obamacare, and so we really don't know what's going to happen there once the Senate takes this up. We hear that they're meeting secretly to discuss how they would change the House version of that, what will happen with pre-existing conditions. The problem for hospitals is a lot of their funding has been improved to some extent by the fact that a whole lot more people have insurance than had before, and so now there's a way to pay bills. If the uncompensated care problem suddenly worsens, I can imagine that the environment would be a whole lot more difficult, and that the demands would be a lot greater on you all in the future. And I would just like for you to just talk a few minutes about the future of philanthropy in terms of what happens with the Healthcare Act and what you see going forward in terms of your ability to fund people who are coming at you for money.
Well, it's a great question, and I don't have a crystal ball. I know what repeal means, but the big question is, what does replace mean? And but in the business that we're in, the most significant part of our funding goes to the safety net clinics in this region. We have a 5-county footprint, so we fund federally qualified health clinics, Communicare in Hayes County, and then the South Texas FQHC that kind of stretches from Lockhart to Luling to Gonzales in Caldwell County, which is the poorest of our counties. And then to the north, we fund Lone Star Circle of Care, which is primarily Williamson County and Bastrop. And then in the central city, our longest standing partner is People's Community Clinic. And what we know is there's already great demand in any of those clinics. And if you go to the community care clinics that are funded by our tax-supported healthcare district, Central Health, all of those rooms are already full. And I suspect, and so the safety net clinic for the population that I described earlier is critical, to having access to health care and having good health. and that's a part of what we're doing. What will that look like 5 years from now? I think there will still be a great need for safety net clinics.
Let me just ask you, some of the partners that you fund, are they turning to technology to more efficiently stretch their dollars? And if so, what kinds of technology are they interested in using to better care for their patients or help their patients self-manage themselves?
Well, in the earlier session, we talked about the bill that just passed the legislature relating to telehealth, and that could have a huge impact on the population I'm describing and low-income people. Because what we have right now is a pretty good primary care safety net system in Central Texas. For the past 10 years, we've spent a lot of time at the foundation making sure that all those clinics have integrated behavioral or mental health in the primary care setting. And that's a huge thing, and we're 10 years into that challenge. But the next challenge, the real big challenge in most safety net providers, not only in this region but across the country, are what happens when you have the diagnosis of cancer or heart disease or diabetes or lung disease or any chronic disease. Access to specialty care is a whole different matter. And telehealth could be part of that, part of that journey.
Greg, since you deal with supporting patients and educating them, are you all using technology to do that kind of work now?
We have a vast majority of our population, and back up for just a minute. In terms of patient support, I mentioned earlier people who have questions about financial and insurance and other things, and that's at the heart of the work that we do. That's available either on the phone, where people can call in and get more personalized care, but they can also do this and self-navigate by using a website and using all the tools and the articles and the chat rooms and the things that are featured there. And what we found is that it's not, it kind of depends upon the person. There's some people who don't want to get up. They want to lay in the bed at any time of the day or night and access the articles and do things from the comfort of their own home in their pajamas. Others want a little bit more personal dialogue. They want to talk to somebody. They want to share with someone. They want to share and exchange ideas and thoughts and have that relationship. And so we try to provide a little bit of both so that it kind of caters to what the patient wants and needs. We are finding that technology can solve problems faster and quicker, and not just information, but education and awareness. And so that's helpful. I think I just got back from a meeting with several of my colleagues in Chicago first of the month with 35,000 cancer oncology doctors, and heard a presentation by IBM on Watson, and using all of the information, the vast array of stuff. Envision for a minute that everything you know about cancer is in one spot, and you can digest it, and you can access it, and you can assimilate the information. So there are a lot of things happening in the technology space, and I think our initiatives are aimed at, okay, where can we take aim at gaps that others aren't filling to kind of be successful with that. I want to talk for just a second about another topic you mentioned about the state of insurance reform and healthcare reform in this country. I think and the insurance piece is important to us. It's not just whether someone is covered or not, but what does that coverage entail? If you have a program that's got a $10,000 or $12,000 deductible, and it doesn't cover pre-existing conditions, and it doesn't cover kids who are going through college because of age limitations, and it may have a cap, a lifetime cap, that may have insurance, but it may not be the type of insurance that's really good. I think that what we are interested in is thinking about access to care and making sure everybody has access to affordable care, not just the insurance, but to affordable care, and making sure that that's available to those folks who need it. Austin is a particular community that has a high percentage of underserved an underinsured community, and so that's an area that we are delving on in our relationship with the Livestrong Cancer Institutes and the Dell Medical School to try to help to work on.
Kathleen, your foundation is kind of unique in a way among the ones here in terms of like being focused on research and technology. Do you fund private businesses or only like the researchers who are in the academic community?
It's generally academic research, but I'd give you an example, and it's a good question from a technology perspective. How can a room full of technology leaders and people who are thinking about how do we bend this curve and change things, and so your innovation and ideas are going to be the way. We had a UTD come to us, and they're looking at virtual reality, and they have culturally appropriate scripts that they can do through virtual reality, not robotics. Virtual reality. So on the screen, you've got a medical student or you've got a student of any kind who needs to be able to learn culturally appropriate ways to deal with people from many, many, many countries. And they may need to figure out what kind of presentation they have as they're trying to figure out the diagnosis. And usually these simulations are done with people who are actors, but that's very hard to leverage. And could you do some virtual reality with students of any kind, medical students in this particular case on this grant, to train them very seamlessly through a question and answer on what is this patient experiencing, how are they experiencing it, and then how is it from their culture appropriate for you to talk with them. And that's a very interesting, beyond robotics, lots and lots and lots of robotics in medicine today, but beyond that, virtual reality into training.
That's definitely a growing area in healthcare and elsewhere. I'm wondering, going forward into the future, do you see the role of your organization changing in some way to meet the needs of the upcoming generation, like the millennials, for example? I came across a statistic when I was looking at this on Philanthropy, which was impressive. 83% of millennials give to organizations. They are of a more philanthropic mindset maybe than a few previous generations were. But they also get reached in different ways too. I've noticed in a lot of millennial funding there's more emphasis on a GoFundMe site, for example, than maybe some kind of traditional site. So I'm wondering, like, how are your organizations changing, number one, to meet the needs of millennials, and number two, to fundraise in ways that are attractive to millennials, or perhaps in Earl's perspective, since you don't do a lot of individual donating, but to reach people and get the word out about the kinds of services that you provide?
I think we have to, as an organization, and quite frankly, as all of the organizations on the panel, we have to find ways to not have the customer come to us, but go to the customer, go to the constituent and reach out to them. And I think we're trying to do that in every way we can, realizing that the patient today, the constituent today, wants more information. They want it in different ways. So whereas in the past, we may have had someone strictly go to a website to get information from us, we ran a pilot project last year on a text to connect program. So is there a way people can engage with us using mobile devices or iPads or other things like that? And so I think we have looked at and explored and have had apps and things like that that will take advantage of technology for people to engage with us in different ways. And it's not just on the programmatic front, but you raise a great point about the use of mobile applications on the fundraising mechanisms. We're all carrying something around. And we're losing a tremendous opportunity if we don't take advantage of that in a fundraising mechanism as well. And so we're doing the same thing, whether it's event fundraising or email campaigns or text to connect type programs, to really, again, reach the constituent where they are, not demanding or asking them to come to us, but for us to outreach. I think the interesting part for us that is fun is trying to get ahead of that and figure out what's the next thing. what's the next latest, greatest way to connect with them and staying ahead of the curve.
Do you have an idea on what that might be?
I don't know that I do. I will tell you this, the one common denominator is that people want more access to more data quicker and faster to make decisions. And I know most of our collaborative efforts have been centered on how can we get the patient inserted at the center of that equation, help direct the care, be informed with all the data. So whether that is they have immediate access to their electronic records, whether they have immediate access to all the different treatment options, the locations for that. More importantly, access to and an understanding of what insurance and things like that mean. If I ask each of you to tell me or to raise your hand if you knew what your insurance covered today, I probably take a hand. Who knows what their insurance covers and doesn't cover? Would you feel really good about it? I've got about 5, and I've got a few that are kind of doing half of this. Envision that tomorrow afternoon a doctor says you've got cancer. You feel like you got a whack on the side of the head. The same thing happens with heart disease or diabetes or other chronic diseases. And so we're trying to find ways to use technology and other things to kind of help address those types of issues.
And would I be correct in assuming that millennials don't respond well to direct mail solicitations for fundraising?
You would be correct.
Yeah, okay. So you're also having to think about the future of fundraising too, and
Correct.
when you mention the mobile devices and all these other things, does that also apply to the fundraising as well?
Very much so.
Okay.
And you have to have a menu of sorts, because you don't want to alienate or forget about the 70-year-old person who may be at higher risk for cancer and who now has more disposable income or wealth to be able to help. You don't want to ignore them. That life and that treatment is just as important. So you end up with a menu of options that says, if I want to connect with a millennial, this is the way I'm going to do it. If I want to connect with others, these are other mechanisms. And you try to balance that portfolio, that menu, to kind of best connect with them.
Earl, you're dying to say something.
I'm dying to say something. I have a question of the group. How many of you during the past 5 years have participated in Amplify Austin? It's a pretty big number of people. It's an effort that's just 5 years old. Our foundation has been encouraging that effort with $1 million each year of matching funds. But what's interesting about Amplify Austin, the nonprofits in this community, over a 24-hour period, raised $10 or $11 million, all through iPhones and electronics. And in the history of Austin, $10 or $11 million in the nonprofit sector had never been raised by anybody individually or collectively in a 24-hour period. And so it started, they may have had a goal of $1 million 5 years ago, and they hit $2 million, and they've exceeded that goal year after year after year. But what's important about that is it has introduced the nonprofit community. There are 600 or 700 nonprofits who participate in that day. It's introduced them to the power of technology and the power of social media. And the second thing that we've learned is that year after year after year, 40% of the contributions received are being received by people who had never contributed to that organization before. So it's also broadening donor bases. But then the next most important statistic is that 40% of the people contributing to Amplify Austin year after year after year are 35 and under. In the nonprofit community, prior to using that technology for just that 24-hour day period, they had never been able to brag about 40% of their donor base being under 35. But that's the power of the question that Mary Ann asked.
Kathleen, I was curious, You mentioned virtual reality as a form of research that is coming to the fore and that you all are funding. I'm wondering, looking ahead, what areas do you see in medical research that is of special interest to you all and that you will see funding into the future? And do your PIs, your investigators team up with businesses in a lot of these projects? And so in some ways, they also are the recipient, at least, of some of the largesse from your foundation.
All fabulous questions. We have a very rich landscape around things we don't know and things we need to learn. And I would say that right now we see, three categories of very, very important work and deep, deep streams of promise. Everything metabolism, cancer certainly, brain is the next frontier, where you can take a look at the power of math that we have today, the power of imaging that's getting so much extraordinary insight at the cellular level, things that we've never been able to see before, study in real time. And so the power of the tools that are now available, side by side the talent that's been built for a long period of time, leads us to a great new opportunity in brain. I would say one of the really exciting stories to just showcase how important new technology is to furthering of research. It's not just money, it's the talent and the tools, and all of those three things together have to be there to really make the breakthroughs that we're talking about. A big example would be Eric Olson, who is long and deep in research and in commercialization and working with companies to bring new companies forward, who runs the Hammond Center for Regenerative Medicine and is working on some gene editing in a neurological environment where you can look around neurological diseases and you can find hundreds of them and not a single one of them has any hope of cure. But today, with gene editing, Olson's lab has been able to take the gene that causes first of all, understand the gene that causes muscular dystrophy, isolate the gene, and such that in young mice, their muscles have stopped atrophying. So we're in the early stages of seeing potential gene editing technologies that are helping us change potentially a neurological disease, which might be the first of several hundred. Just as an example of new technology, great deep talent. Certainly companies will want to work on that as we get further into it, and the power of great talent put together to really try to solve some of the profound things we haven't solved.
Is this the CRISPR-Cas9 gene? Okay, so you all will hear a lot about CRISPR, if you haven't already, in the future, because it's relatively cheap technology and it can potentially cure diseases. And I'm in the rare disease community on the board of a rare disease, and they don't really have any treatments. There's very few clinical trials, and they are so interested in the potential for potentially taking the mutated gene out, fixing it in the lab, putting it back into the person, or even doing it inside the body. They're not there yet. It will be probably a few years, but it's one of those fields in medicine that's moving incredibly fast and is so exciting because of what it can do. So glad to hear that that's an interest of your foundation going into the future and the potential there for that.
And I want to touch on another major shift that's occurring nationally in philanthropy, health philanthropy. It's shifting the conversation from healthcare to health. And it's focusing on the social determinants of health, and that's work done by the Robert Wood Johnson Foundation 7 or 8 years ago. And the social determinants of health are all about health, not healthcare. Your access to everything, to most of the things we've talked about today, the healthcare system, that drives 20% of your health. And the other 80% of health is not driven by the clinical setting at all. It's not driven by your ability to access health care. It's driven by the zip code you live in. It's driven by what you eat, how much you exercise. It's driven by genetics and several other factors. And we have been studying the social determinants of health for the past 2 or 3 years in our foundation. And so when we released our strategic plan for the next 3 to 5 years just a couple of months ago, that's the future direction of what we're focused on. And you might say, well, how is that different? Well, 3 years ago, if you'd asked any of our board members what the St. David's Foundation do, they would have said, oh, we're all about providing access to health care for low-income people. And now we're all about helping Austin and its people, or Central Texas, become the healthiest community in the world. And so it seems like a minor shift, but it's a huge shift, because we are really moving more and more of our resources to the other 80% of the determinants that shape everybody's health in this room.
Well, Greg, I always think of the Livestrong Foundation as really for the survivors of cancer, but, Earl raises a good point here about potentially preventing yourself from getting cancer. And to what extent is your foundation looking at ways to either use technology or help people who may have some risk factors for cancer, but don't have cancer, prevent it?
I think most of our effort for 20 years has been focused on the patient and the patient and the constituent and the caregiver in a particular scenario. And like Earl mentioned, part of that is medical related. It's about the health care. But a big aspect of that is around the nutrition and the fitness and the health and the wellness. I think the primary relationship that we have had in our history that has helped kind of influence that is our relationship with Livestrong.com, which is a health wellness site that has access to a lot of information more about health, diet, nutrition, wellness, fitness components of that. We have, especially in the last few years, have focused much of our energy specifically in the cancer space and on the needs of the patient, and quite frankly, keeping track and being able to handle that demand. That demand has grown at double digits for the last few years, and we don't see that slowing down. But we do, like Earl mentioned, believe that there is much more than just the health care or the medical treatment side of this. It's got to start with prevention. It's got to start with diet and nutrition and exercise and wellness. I think the other element of this is that a lot of these chronic diseases, including cancer, we know the solutions to, and we know many of the problems associated with it. Half of these things we already know solutions to if we only did what we know, and if we actually executed on what we know. We know we need to eat better, but we don't. We know we need to have fitness levels and exercise each day, but we don't. We know we need to stay away from tobacco products, but we don't. Those are simple things that if we did every day. And so many of the initiatives that we're doing inside the organization are trying to take aim at those gaps that we already know exist, and yet how can we influence personal behavior and human behavior to kind of have a better impact?
With Congress now looking to change the healthcare system that we've lived under for several years now, do you all contact your Congress members and tell them you hope that they will do X, Y, and Z when they consider passing a bill? What do you lobby? I mean, what kind of communications are you having with your members of Congress about how they're going to change healthcare in America?
One of our strategic initiatives as an organization is kind of reflecting the patient voice. to our political leaders and to those other groups. Just came back from One Voice Against Cancer on Capitol Hill in Washington, D.C., the 4th of June. An excellent opportunity for us to go and talk about what kind of impact these healthcare changes have on a cancer patient, We've done the same thing here with the Cancer Prevention and Research Institute on a statewide basis. That, for many of y'all, you know that passed a $3 billion proposition to help invest in infrastructure and research and prevention technologies in Texas. So we've been very advocate on that. And again, our voice is really just reflecting kind of the patient perspective, not so much the medical side of things or the clinical side.
So are the patients concerned about what's being talked about here?
Very much so. I mentioned earlier, and I asked for a raise of hands of people who knew something about their insurance. And that's what something you know about. If I said, wait a minute, insurance is in flux, and we don't know what that healthcare system is going to look like, well, then everybody would have questions. And so, yeah, they're very, very concerned about what that looks like.
You know, and this is going to be talked about later, but the cost of cancer drugs is just outrageous. And I think most people, you know, if they didn't have coverage, I mean, it's a life and death situation for people. And when I was a reporter, I would get calls pretty regularly from people who didn't have health insurance and they were stage 4 cancer, and I just felt like I was talking to somebody who wasn't going to be around for very long. And it was really difficult thinking about that and thinking about the pre-existing conditions and who wants to give up, you know, the potential to have coverage when you have a pre-existing condition, especially if it's cancer. I don't think many people would be racing to give that up, given the chance. Kathleen, I know that I don't know if you're restricted from lobbying in your role, but do you talk to Congress about medical research? Is a huge issue. NIH funding, I think you all know that there are plans to reduce all of that, and some people say that they're concerned about science. Where do we go with some of the changes in the budget that are being proposed in Congress? So do you have a role in talking to your members about that in Congress?
Well, certainly our stakeholders care deeply. We don't spend a lot of our funds on lobbying, and that's by design of the kind of charitable corporation we are. There's a big governmental affairs effort, of course, at UT Southwestern, and things like research funding with secret and state at all levels, and certainly with NIH and federal funding. All of those are critical revenue streams that if you cut off future funding of grants, affect young investigators, they can affect current investigators with new projects. So that's extremely concerning, of course, if that were to ever have legs. One thing that we are observing today is that NIH seems to have very, very strong bipartisan support, that people understand that you can't make progress in changing disease and changing outcome without studying. So what we learn tomorrow to change something has to be learned in the lab and then educated across the environment. So if you've got entities, especially public entities, that have a requirement to serve the public, then part of what you learn needs to be extended back to the public. And I think part of what NIH knows is that as we learn, national impacts can be made and furthered, and the state knows, I think, that a healthy population and people who know more and learn more and can have higher level access to care are much more beneficial to the state than an unhealthy population. So by definition, I think we do have some level of understanding that research is the answer, and we have a really lovely stakeholder who loves to say, science is the answer. And she just keeps everybody focused on science is the answer. And it's very true.
We do want to leave time for audience questions. Is this supposed to be over at noon or 12:15? 12:10. Okay, so we got a few. I would like to ask one other question, and that is, even though you don't fund businesses directly, by and large, are there ways that private industry can benefit from healthcare philanthropy, either through your entity or in some other way that people may want to know about if they have a healthcare solution that they want to share, and also potentially share in funding with you all. Y'all look like your wheels are turning here. Earl?
Well, I spent 31 years in business before I stepped into the foundation business. And one of our core values at Maxwell Lock and Ritter is we expected our accountants to be actively involved in the community. And that was just a core value. And that CPA firm was very involved in the community. And what every business should be doing is engaging your people in nonprofits like the 65 Health and Human Services nonprofits that we support, because they all have boards of somewhere between 12 and 25 people, and the vast majority of those people come from the business sector. And your employees will get so much more by participating in those community activities through the nonprofit sector in Central Texas. You know, a lot of those, the leadership they'll learn working in nonprofit organizations and in the community is probably better than any leadership program the corporation will ever provide them. So I would just encourage activism and participation in the nonprofit sector, because when we gather the CEOs and the chairmen of the board and the development directors of our 65 grant partners, that means there's about 200 people in the room. And when you give away a lot of money and you invite your grant partners to something, it's called the power of convening, they all come. But when I look out at that room of 200 people, and I recognize the work that those 65 organizations are doing in this community very quietly, behind the scenes, to help this community be healthy, it's just amazing. I mean, I get emotional when I'm in front of that group of wonderful people. But the people you work with should be participating in that in some way.
Kathleen, you want to take a crack at that?
What angle would you like for me to
Well,
sort of think through?
I would think that since most of your funding goes to the academic community, I'm wondering if, businesses should be looking at people who are doing specific research that maybe they have a solution for, and if there can be a joint grant application, or if they need to go through the academic researcher. But I may be not even thinking of ways that businesses could benefit from the philanthropy that your organization does, but that's the first one that strikes me. So,
Well, there's so many good examples. That helps me sort of narrow in on one. We have a leader. This could have been anybody. He just jumped in with a great business mind, who 30 years ago came on the board, and he saw of our foundation, and he saw that this academic medical center that we talked about earlier has grown a profound research enterprise, a tremendous educational enterprise, has faculty operating in our safety net hospital, in our children's hospital, in our VA hospital, in many different hospitals, but had not well developed the university clinics and hospitals that you see today as part of this medical center. So that meant that there were a lot of people who had access to the safety net hospital, but the academic medical advances weren't necessarily being made available to everybody in even one community by virtue of having not well developed that clinical care arm of the university hospital system. So he just started talking about why not growing the clinical care side by side the medical center. So back to the original introductory comment I made about this is an organization that helps catalyze the community to the medical center and other medical enterprises. It's also the catalyst that brings the medical center to the community in the broadest sense. And so bringing the community in and bringing the advances out and making them broadly available is a huge leap forward. He never has stopped for the last 30 years working on the expansion of quality clinical care by this medically advanced enterprise. And that's a community leader, side by side, the medical center. But I could name you 10 stories that are like this, where somebody cared about something and they saw a need and they could rally the community. It started with how this whole thing started. It was a product of the community. Today, initiatives are funded and thought through together in a very collaborative sense. And I think it's made the community, I know it's made the community stronger, and I know it's made the academic enterprise stronger by having the community business-minded, process-minded, technology-minded, future-minded, young people-minded voices saying, how about this and why not this, and being pretty demanding.
Well, I mean, that was a really insightful thing, because as we've heard earlier, and as many of you know, the care is transitioning to those clinics so that the outpatients can be taken care of. So people who even had hospital in their title, like the Seton family of hospitals, is now the Seton Healthcare family, because they realize that, you know, the action right now is in outpatient areas and keeping people healthy so that they don't need to go into the hospital. So kudos to that smart visionary who you all got on your board. Greg?
Several different things come to mind, and I'll start maybe a little more globally and kind of narrow down on specific things of the foundation. I think, first of all, I just would continue to encourage the public and the members here to be very active in things at your own companies, at your own communities, at your own organizations. There's members here from the wellness communities in their own companies, things like that where you can have a little bit more passive involvement, but you're still involved in what goes on there, I think is really critical. I think the one thing that we try to do and strive at the organization is, you know, we don't come up with these ideas ourselves. Okay. Another thing unique about the organization is we listen to the challenges and the gaps and the problems that the patients and constituents are having, and we try to cater to what their challenges and their problems are. So even if you're a survey participant and you're providing a simple answer on an experiment or your experience as it went through the healthcare system, that type of information is invaluable to us. We have a survey in market right now that's out to the fertility world, where you have young couples and young women who may have been diagnosed with a chronic disease and need help with understanding their fertility options, because at some point in time they may want to have children. And so we
freeze eggs or sperm or whatever.
Exactly. What does that look like, and what are their needs, and what are the challenges and frustrations and things they have? But all of the programs that we develop are not things that we're 50 brilliant minds coming up with the ideas ourselves. We're listening to the gaps. Over our history, we've done a bunch of different ways to kind of solicit that advice. We've had several years ago, we had a competition called the Big C competition, where we literally we provided all the information, all the data that we knew about cancer, and had that out there in the world. And we said, come with your ideas. We're going to award prizes. We're going to offer mentorships. We're going to offer venture capital assistance in kind of developing that. So come to us with your ideas. And we literally had 300 different people apply from over 60 different countries around the world.
Wow.
So there are a variety of things like that we do.
How big was the prize?
The prize was relatively small. I think the grand prize was a $25,000 prize. But what ended up happening is people got mentorship, they got business leaders together, they got industry experts to kind of help them put together and model their product or service. I think locally, one other thing that I haven't really hit upon very heavily here is our relationship in building the Livestrong Cancer Institutes at the Dell Medical School. We have an opportunity to start with a blank sheet of paper. In fact, are starting with a blank sheet of paper, and how that cancer care can be delivered, and more importantly, how a patient or a constituent can be right at the center of it. And so we have 6 different focus groups that are involving different members of the community, whether it's research or patient support or education or other elements like that. And so anytime you have an opportunity to be a part of that type of group, it's very, very helpful to us, and that will help kind of change the trajectory of not just the healthcare that Earl alluded to earlier, but the wellness, fitness, nutrition angles that are really so important.
I'd like to hear from the audience, and I'll take the first question.
First of all, I want to thank you all for being here because the work that you do is so important in our communities. And I work for a company called Cloud9, and we work with the Medicaid population here as well. I think two things come to mind from what you said. First, I want to just put another plug into what Earl said about getting involved in the service. Sitting on these boards really do get a sense for what the issues are at our community centers that deal with integrated health, behavioral health. And they're being asked to do a lot with a little. They probably they benefit tremendously from foundations that provide this funding. They're up against cuts in Medicaid, 30% capacity at a lot of these centers because of high no-show rates. They're dealing with the superutilizers in our community. In San Antonio alone, there were 10,000 patients that drove $200 million in medical costs and $1.1 billion in total social services spent in that city. So we need to be solving the superutilizers issue in part to solve for the rest of the population that doesn't get as much care because one person is making 5 trips to an ER and nobody's continuing that care outside. So just some inspiration for some of the technology companies here. My question is for, from the nonprofit side, what can we be doing to convene committees, smart startup companies that have solutions like this to help change the operating model, to help our providers at these community centers do more with their patients so that the kinds of things that we see at Kaiser Permanente doing 50% virtual care are things that we can get into our communities where a nonprofit executive is not incentivized to take a risk relative to keeping their family on their pension.
Did everybody get to hear the question?
I could give you a Fort Worth example.
Okay.
It might translate. So just as a story of somebody caring for a long time, again, about a community. First, it starts with caring about your community, I think, and being able to mobilize the community around good ideas. Fort Worth, so prevention is a pretty recent topic in my experience. Even though we've been learning about how to prevent through research for a long time, we haven't really been talking about healthcare providers stepping into it. The Moncrief family in Fort Worth started with gifts because their daughter had died of cancer in cancer radiology. Radiology, it became a commodity. They didn't need a separate standalone radiology, but they had a vision about cancer, which included prevention, long before anybody started really talking about it. Had the funds with the community and the vision to really buy land and build a facility that doesn't just house cancer treatment, but has beautiful facilities for teaching cooking and learning about cooking, and designed for community to come in and be able to have an auditorium with cooking demonstrations. There are real things that facilities allow, but it starts with, does the community care about it, and will they come, and are there support groups in the community to bring the community partners that need to come? And they're coming. It's a wonderful thing. Post-cancer treatment also is an unaddressed gap, and so the other idea was add post-treatment counseling facilities so that there's a place to come, and that communities that are post-cancer are also having places to meet and experts from whom to learn. That's the power of the community coming together with lots of social groups associated.
Earl wants to weigh in on this.
Yeah, it's a great question. And about 3 years ago, we finally, as a foundation, took the plunge into capacity building. And we created a capacity academy for 7 of our 65 organizations. And we have been helping them, as a cohort group, build capacity over the last 3 years. Just
What
this
does that
year,
mean, build capacity?
it's to increase the infrastructure of the nonprofit so they can serve more people.
Okay.
And it's trying to get the nonprofit to focus on the systems that businesses take for granted, that the nonprofit community is not encouraged to do. So of our 65, and we've expanded that to another 7, so we now have 14 of our 65 grant partners. The other thing that we did along the lines of your question is a year and a half ago, we built and moved into a new building. And as part of that building, we created a very large space on the 6th floor called the St. David's Foundation Innovation Center. And we are encouraging nonprofits, not one nonprofit with 7 or 8 people, but 7 or 8 nonprofits with several people coming together to discuss important public policy issues and health and human services issues. And the response to that innovation center has been significant. I don't know
Where's
who's
the innovation come in on that?
Well, we're driving, helping to drive some of the conversations like the one we're having here and the question that you asked, and encouraging the collaboration among the health and human services providers. And I don't know who's there today, but I can almost assure you that in one of the 5 conference rooms, there are probably 2 or more collaborative groups of nonprofits having those kinds of conversations. And it's something we weren't doing or even thinking about 5 years ago. But the capacity building, now many of the companies in this room, the CEOs and the executives, have had an executive coach for some time. Very few nonprofit boards are going to spend money on an executive coach. But I can tell you, being a CEO in a nonprofit is every bit as difficult as being the CEO of any company in this room. But the CEOs of nonprofits are not expected to have executive coaches because that's not because the money should be going to direct expenses. They're not expected to spend money on marketing and fundraising or a sustainable revenue model. They're not expected to train their people and have a really robust human resources function. And the list goes on and on. The things that business leaders take for granted, for some reason, our society for 400 years has told the nonprofit leaders that no, you have to get by on hand-me-down computers, on the computers of 2 or 3 generations ago, or you have to, when you move into new space, well, you need to find some used furniture or somebody that'll donate furniture to you. We're trying to change that mindset through this funny thing called capacity building. Because if you could build that capacity and at least level the playing field with the tools that nonprofits have, with the tools that businesses have, it'd be a great benefit to our society. That's my story.
I'd like to take some more questions, yes?
You mentioned the financial and environmental and physical barriers that affect health. I was curious if there are technology inequities that you see in the populations that you and the organizations you support serve, and if so, what are those inequities and what's being done to address them?
So the question is what kinds of technology inequities do you see with the populations that you're trying to serve, and what are you doing to address that?
I think one of the biggest things that we see and hear about from the patients is more that if they're served in a local clinic and they need specialized care, what's being done easily and quickly to have access to medical records and treatment things so that they can get medical records from one doctor to another immediately, as opposed to fill out this authorization form, come back 4 days from now, and maybe it'll be ready and maybe it won't. Obviously, with more advancements in EMR, electronic medical records, things like that are advancing, but there's still a lot of challenges with that, where you have a medical record that is large for an extensive client who's been treated in a local clinic and needs specialized care somewhere else. I think that's one of the biggest concerns we have. I think the other that we're trying to help with is finding ways for patients to be able to keep track of their own records. We have a guidebook and a journal that helps people to keep track of their receipts, to keep track of the notes that they made during doctor's appointments and things like that. So we're trying to find ways to automate those types of things ourselves.
Next question? Oh, Earl. You go ahead.
I was just going to say, the young man or woman who delivers pizza to your house this evening knows more about your consumer habits and your pizza habits than most specialists do when you're referred by your primary care physician to the specialist. And the specialist, when you walk into that room, I'm generalizing to make a point, but the vast majority of those experiences by the consumer are not as good as what you have at the ski rental shop in Colorado or the pizza shop. Because what's the first thing you're handed by the receptionist when you show up at the specialist office? And there is a clipboard. And you're expected to remember your medical history and your parents' medical history and maybe your siblings' medical history. And the healthcare profession should be ashamed of itself that we haven't, and I'm a part of that we aren't farther along in sharing health records. And because it's the only, it's an industry that represents 16 or 19% of GDP, and it's the only industry that still operates out of manila folders and clipboards.
I've always wondered why that is.
Because healthcare changes at glacial speed.
But a lot, universities too, but they're not that behind, are they, in technology?
Yeah, I agree. I think it was a long time coming for privacy reasons, and Tommy Thompson, when he was Health and Human Services, was really championing the electronic record, and a lot of people wondered if it would ever happen, and we're here.
And it has been controversial. There's been a lot of complaints about that.
But here's the good news. Dr. Hubert from Dallas, who I met last night over dinner, because he's going to be a speaker at 1 or 1:30 or so. Don't leave until you've heard from the doctor. Because while I was eating a ribeye steak last night at dinner, he pulls out his iPhone and wants to do an EKG on me. Because he has the ability of doing 8 EKGs at a dinner table.
Wow.
And so now that's not the health information exchange that I'm being critical of, but on the app side of things, it is very quickly, technology is revolutionizing healthcare. And it will really revolutionize the healthcare that my parents, who are 86 and 87, will eventually, if they live long enough, will receive in their home. So be sure to stay and listen to whatever he has to present, because I was really impressed last night. So there is a bright side to this.
Yeah, and a lot of it's consumer driven. That's the reality of it, is it's a reaction to what the consumers are saying. Hey, we're using apps all day long. How come you can't give me my prescription on an app, or my instructions? And
Marianne, I didn't answer, and it was a really thoughtful question on technology disparity. If I could just say, there is a very interesting initiative in mental health that researchers in psychiatry are pushing very hard into schools, and it's we know that if we can diagnose early, we can treat much more successfully a child who's presenting with depression, or a teen or a young adult, much better than we can in the 40s. So early diagnosis is a huge opportunity. We know it's an opportunity, and so how do you address everybody with that opportunity? And as we get into the schools through this initiative of the Center for Depression and Research, there's an iPad application called Vital Signs 6 that's being introduced to thousands of young people. And it's also being introduced to adults in lots of physician referral network offices that are being aggregated. So let's talk about 7,000 physicians and lots of schools over the course of time who can answer on an iPad, whomever you are, this is how I feel about, and you answer the questions. And it really does bring technology and diagnosis forward through an iPad application. And I really hope that there's a lot more of that sort of.
Is it a depression screening tool? Okay.
And she's touching on a couple of really important points. But the one is, I think the future you're going to hear more and more about trauma-informed care on the front end of life. And these are children who are experiencing trauma. And I'm not familiar with the tool that you just mentioned, but I am familiar with the ACEs score that 10 questions you can ask any 5-year-old. And based on the answers to those 10 ACEs questions, you can almost predict how you can almost predict their mental health that they'll experience by their mid-30s, because it's shaped so soon. So trauma-informed care on this end of life is going to become huge, I think. And then on this end of life, it was mentioned earlier in the morning, palliative care is going to become huge. Now, when you mention palliative care to most lay people, if they have ever heard of the term, they think hospice care. But hospice care is the last few weeks or maybe months of life. But what's happening is we're reshaping the whole way of approaching the last 10 or 20 years of life. And I think you'll see that happen over the next 10 years. And palliative care will be a part of that. But also the apps that Dr. Hubert is working on will greatly shape that whole question, so that so much of the health care that we've been talking about that's provided by hospitals will occur in the home, especially in those two vulnerable populations. And then the third most vulnerable population beyond those two, the third most are women, and really especially low-income women. And
Well, that's a whole other subject about defunding Planned Parenthood and all that.
yeah, I thought you'd get to that.
Meant to.
One
Yeah.
other comment about your technology. I don't know that I see as many technology challenges as I see that we're not able to use technology to leverage that more fully. I think there are too many silos about patient data. I think there's too many silos by organizations, by institutions, by healthcare deals. I think there's a lack of awareness on a patient's point that if it's de-identified, in a perfect world, if you had all patient data, treatment deals, scenarios, outcomes, you could almost instantaneously understand and predict what is going to be successful based upon what has happened in the past with similar patients. But right now there's so many silos, I think, that are up that prohibit that type of real-time analysis from happening. There's pockets of data in so many different places. So I don't know, I think science and technology has advanced so fast. I don't think it's the ones and the zeros that are slowing us down. I think it's the walls to access that data and have that data that can be shared and used in real-time solutions. So I think that's really it, more than the technology or the devices.
One last question from the gentleman in the front.
Thank you. Namir Majed, and I'm on the software technology side of things as well in healthcare. But also I run a nonprofit that deals with healthcare. The safety net side, so we run free clinics for people here in Austin that don't have the appropriate care. So I commend all of you on the work that you guys are doing because ultimately it's going specifically to that indigent population who can't afford it. So I can relate on that level. I guess from a technology standpoint, maybe to Greg, the question comes to, yes, there's technologies from a consumer-directed perspective that we can build mobile apps and things like that. But if those indigent populations aren't aware of those technologies, it's of no benefit. Are there things that Livestrong Foundation is doing to encourage usership of these through awareness? So social media, a big part of getting the word out on those types of services and technology.
Exactly right. We're trying to use everything we can, but I will tell you, it's not just social media, because quite frankly, social media is only going to be accessible if you have that device, if you have that technology. And if you're not using that technology and don't have that device, well, then you're not going to see it. So our outreach efforts are a broad array of different things. Some of them are hard copy publications, but yes, email, but yes, social media. We've done things in doctor offices and clinics to try to get the word out. So we can't just rely on social media because, again, you have to have that device. And we have one of the largest social media followings around. We can instantly touch base with 3 or 4 million people. But it doesn't reach everyone. It still reaches that person who has a device, not the vast population. And we have to be able to find ways to reach that underserved community. We've done that in the past with Spanish websites. We've done that with training of promotorists and nurses in different areas. So we try a wide variety of different ways to reach that population. Again, back to a comment I made, we can't rely on them to come to us. We have to be creative and innovative to try to find ways to reach out to them and engage them where they live, as opposed to the other way around.
Greg, that sounded like a good closing statement there. Do either one of you two want to say one last takeaway that was like what Greg said about philanthropy going forward?
It's too high a bar.
That was beautiful.
I just appreciate how tremendously important all this is. Having a dialogue set, convening, but having a dialogue like this with an audience that cares gives us all great hope, I think. Thank you.
Earl, do you have a last?
I'll say the same. Thank you.
Thank our panel. They were great.
We'll now lead out to lunch. Your name badge is your payment for lunch, and we'll go. Jonathan, can you lead me right there? Jonathan, right here, will lead us out to lunch. Let's come back and convene at 1:10. When you connect, I want you to